My name is Stacy Whalen, and for the record, if I were doing this in front of a live class, I would have one of those old-fashioned pointers to point at what I'm talking about in the slideshow versus one of the little red things that fly up there. For the sake of this, I'm going to try as we go through the slides to tell you what I'm talking about via left, right, that type of stuff. Okay, without further ado, on to the presentation. Hi, I'm Stacy Whalen. I'm a registered nurse at Radiation Oncology. I've been a nurse for 20 years at Lancaster General. I had worked at clean gynecological surgical floor, postpartum couplet care. From there, I went to Susquehanna Division up in Columbia, and there I was rented with the walls. Specialty service people came from York County and also Lancaster County up there to service the patients. So I worked with a few GI doctors, gynecological doctors, urologists, occupational medicine, cardiologists, general surgeons, orthopedics, and even podiatry. From there, then, I went to radiation oncology. So let's talk about the objectives we're going to try and have through this presentation. Of course, we're going to review terminology. We are going to talk about the radiation machines, assorted radiation procedures. We're going to review radiation side effects. We're just going to touch on that a little bit because at the end, when we talk about the assignments due for the next time we're in class, you will be put in groups and you will go ahead and be assigned a cancer diagnosis, and the three of you will need to come up with a plan on how to present that to the students. There will also be a Blackboard assignment due in between the two of those. If at any time you have any questions, please do not hesitate to raise your hand or speak out. The staff needed to take care of someone with cancer for radiation. We, of course, need the physicians. The physicians in the department, they do consults, new patients. We do follow-ups. They also do the planning of the radiation treatment and they oversee the treatment. They make sure everything lines up perfectly every week. They see the physicians every week. They see the patients every week. And they also see them as needed if the nurse thinks that there's a problem that's something that can't be managed. Next to the physicians, the next important person would be the physics department. They're in charge of the safe and effective use of the whole radioactive equipment, the machines, the material. They do all the calibrations, and they also take care of a good bit of the final plan before it heads to the physician's desk. Certain treatments called high-dose radiation treatments are actually overseen by the physics department and the physician while the patient's getting the treatment. All treatments start with a radiation therapist and a dosimetrist. The dosimetrists, they calculate the radiation dose and the placement. They're the first step in deciding on the planning and how best to position the patient and how the angle of the beam is going to come in. From there, they go to the physics, and then from there, they go to the physicians, and then only then can a patient actually start treatment safely. The daily people who administer the radiation would be your radiation therapists. They're in charge of making sure the patients are immobilized properly with positioning. They're in charge of safe delivery. There are so many safety features to radiation we're not going to get into, but they're in charge of making sure that's maintained every day, along with proper documentation so that billing can be collected. And then you have the nurses. We, of course, gather data. We manage side effects. We triage, we educate, we assist in procedures. We're the front line. Before a patient would see a physician, they always see a nurse first. Our terminology tonight, we have a couple different things. We have what's called a simple plan. So anytime someone comes for radiation, everything is all about body positioning and how many angles the beam's coming in from. A simple planning would be your basic, anterior, posterior, a one field setup. Imagine just like a basic chest x-ray, or someone broke a bone and you're getting one x-ray, that type of things. What we see a lot with simple planning would be the extremities or something called a heterotropic hip x-ray. When people have fractured hips and they throw a lot of extra calcium spurs after or right before, in the real world, right before is what we like, they get that hip replaced. They come in for one dose of radiation and that stops the body from producing the extra calcium spurs, which would cause a problem down the road with that joint being stuck together and not moving. The next thing would be the intermediate planning. So that's kind of 3 or more different types of angles that come in. And you can do that with breasts and pelvic treatments. You know, when you do a breast field, you can come in from 2 to 4 different angles. When you do a pelvis, you can come in from 2 to 4 different angles, depending on what the patient's disease is and what they're trying to cover. And then the really tough stuff would be the complex, the really high complex blocking. This is something you're going to see that has all kinds of special immobilization devices. There's going to be multiple treatment areas. You're going to see this with certain lung patients because you just want to treat that disease with minimal lung around it. You'll see this with people who have brain tumors, GBMs, like Mr. Biden right now, or Biden, excuse me. You know, he has a GBM, very hard to treat, very aggressive cancer, you know, but you want to treat just that one area and save the rest of the brain. So that's the type of treatment that is. And you'll see this a lot with the throat type of cancers. There's so much activity in the throat that you'll want to make sure you're just getting what you need to with a tight margin and not really expanding too much into the tissue that doesn't have any type of cancer, because the side effects can be devastating with eating, drinking, swallowing, maintaining weight. This is where everything starts. This is what we call our CAT scan simulator machine. And it is a CAT scan. It is not diagnostic, so it does not look for did the tumor grow. The radiology physicians only read it that the targeted area for radiation was maintained. They do not look at it to see has anything changed from the last CAT scan. Anytime someone needs radiation, they always start with a CAT scan simulator machine. The biggest key to radiation is immobilization devices. You need to be able to duplicate their position every single day the same way you did on that CAT scan machine. And that's done using different devices. On the right-hand side is the VacLock bag. So that's like a bean bag. And the patient is put in that bag, and then all the air is sucked out, and it's kind of molded around them. That bag then is labeled as Mr. Smith's bag, and every day it's put on the table, with or without an elevation device. Mr. Smith is put in that. And it's duplicated all the way to the fact of how their legs are. You know, if their legs are not in that bag, they are secured in a certain fashion, and every day that fashion is recorded and duplicated. In the middle is something called an aquaplast mask. Now, these are very uncomfortable for patients. But if you're treating a brain and the nose is 2 millimeters to the right or left, you just missed part of the tumor. So these are flat things that are heated, and then they are stretched over the patient's head or head and shoulders, as you see, and they're then bolted to the table every day. They're snapped and secured in so that that head and shoulder is not moving in any set way. The other things that you see there on the right, which are black, are your basic things you see in nursing for positioning, wedges, knee wedges, that type of stuff. And on the bottom right is a special head thing. There are no pillows on these tables. These tables are uncomfortable. There is nothing soft and cushy, because if there were, the machine would think that's part of the skin, and from there it would treat the wrong area. So this is a special kind of head thing that someone with, say, a throat cancer is going to have this head thing devised. From there, then they're going to have that mask put over their head, and then they're going to be put on the table every single day. Slide here shows one of the actual machines. It's called a linear accelerator. It is man-made radiation, so it's only putting radiation or radiation beams out when the machine is turned on by the therapist, and it stops when the machine is turned off. Up at the top there of the round thing, you'll see something called, or if you were in the room, a multi-leaf collimator. In the old days, if someone had radiation, they would put lead aprons over them. With the old radiation for this type of thing, they would have special lead blocks that would be stuffed above the patient's head to block out what shouldn't be radiated to keep people safe. Now, with the new machines, there's these 300 plus leaves that will conform to that patient's particular treatment plan that was designed in that CAT scan simulation room. Every day, the patient's immobilization devices are taken out. There's daily images that show, gee, is everything lining up 100%? And if not, the machine's going to flag, things are going to have to be checked. And then weekly, there's dose checks to make sure the dose is where it's supposed to be. And the last part of this slide, the DIBH, that is fairly new technique in the last 3 to 5 years. It's the double inspiration breath hold. So if you have breast cancer on the left, you're put in a position with your arms above your head, you're in the immobilization device, and the beam does not go straight down because we don't want to treat the lung and heart. Interestingly enough, the lung hugs the breast tissue and the breast tissue hugs the chest wall. So even though you're coming in from the sides, part of the lung and part of the pericardial sac will be treated. They have discovered that if you have a lady hold her breath, that drops the heart down in the cavity, therefore it does not get treatment. A lady can be told to hold her breath 45, 90 seconds, depending on how big her lungs can expand and how far the heart drops down. Very hard for people who say have COPD, a cough, anything like that. So it is very uncomfortable for some of the population. This is another machine. It's called a tomotherapy machine. This is used a lot with head and neck cancers, prostate cancers, and certain lung cancers. Every day before the patient would get the radiation, a CAT scan is administered to make sure that they are targeting exactly where they want to do. So it gives you a 3D image with the use of the CAT scan so that everything is exactly perfect. And then the radiation is delivered in a spiral pattern using, again, multi-leaf collimators, which means the radiation comes in 360 different degrees as they are slowly being fed through the machine. So that way it's targeting exactly what you want and sparing the other tissue around it. This is called a high-dose remote afterloader. Now this particular machine, in the base of it, has an actual live source. So it is always radioactive as soon as the source is out of the machine. This has been a huge thing in radiation 15, 20 years ago. This is a seed that gets implanted into patients' cavities and tissue. It does the treatment and then it's retracted back into the machine. Excuse me, Sam, did you have a question? Wait till you hear this. So prior to this high-dose remote afterloader, if someone had a gynecological cancer, they would actually put the radioactive seed into the uterine cavity, and it would stay there for 5 days, day and night. They would be radioactive because it was a live source in the hospital. No family and friends could visit. Nurses rarely went in except for the bare necessities, and they had to stay in bed flat on their back that whole time because they were considered radioactive. Now with this machine, we can go ahead and add these catheter cables, as you see coming out of the machine on the right. It can do up to 26 of them, okay? You can then hook them to catheters that have been implanted into tissues via surgery. And then the machine will send that radioactive seed in and out of each catheter every time for the treatment, put it back in the machine, take it to the next catheter, bring it back out, and effectively treat the patient on an outpatient basis. And after this, depending on what the procedure is, after it's all finished, the patient goes home and they're not radioactive. And so therefore they don't have to worry about their loved ones and what they're doing to the environment around them. New onto the environment is, again, another one of these brachytherapies or internal type of radiation. And this is called mammocyte. I know, Sam, it's very exciting. So what happens here is that, say you have a breast cancer. They take the lump out, you're considered cured, but just like an insurance policy, you're not 100%. You're probably 85-ish or so. So let's boost that cure rate, because what if one tiny cell fell into the cavity after the surgery? You're right, Julian. It's microscopic. You can't see if one cell fell back until months or years later. So they come in for some radiation as an extra insurance policy, and that bumps it up to about 98.5, according to Dr. Singapore. With the mammocyte brachytherapy, what happens is they take the cancer out, And if the patient's a candidate, meaning their breast is not too big, it's not too small, the tumor's not too close to the skin surface, the tumor's not too close to the chest wall, because again, we won't want to treat lung or heart here. And if it's too close to the skin, what's going to happen is you're going to have a really brisk skin reaction. Well, we'll talk about that, Susan, later on at the end of the slides when we talk a little bit about side effects. So what they do then is they take that all out, and once it's deemed that the patient's a candidate after the pathology is back, they go back into the same surgical site and they insert this catheter and they inflate this balloon because the balloon needs to cover that whole area. After that's done like that, they come for their radiation CAT scan simulation process, and then they start treatment the next Monday. This treatment, and again, this catheter hangs out of their breast the whole time, and they can't shower. They can wash their hair, but they can't get a shower without getting wet. This hangs out of the breast. They have to manage cleaning it over the weekend. Once they come to the departments, usually the departments will take care of the cleaning. And then they come twice a day to have that high dose radiation radioactive live source fed out of the machine into the catheter, into the balloon. And then the physics, dosimetry, and physicians plan how quickly they need to withdraw that radioactive seed. This particular procedure for whoever is eligible takes radiation from about 33 days, Monday through Friday, to twice a day for 1 week. Huge for our working women in Lancaster. Another internal procedure that we use with this particular machine is called tandem and ovoid brachytherapy. This is the one I said that prior to that machine, it was inpatient and the radioactive source was left in the patient. Now it's outpatient. It is an all-day affair. With the other types of radiation, they used to, well, what they do is they do the CAT scan simulation and then the patient comes back later. With an internal procedure, because this apparatus is inserted into the uterus and the vagina, every time they come for one of these, and most ladies get 5, when that's inserted, they have to go to the radiation planning process again. Because as the treatment goes on, the tumor and the anatomy are kind of changing and shrinking. Well, yes, Sam, it does get smaller, the tumor, with any luck. And not only that, though, sometimes the vaginal canal gets smaller. So you can't assume, if you would assume that it was the same as day 1 when you did internal as day 5, you might be treating bowel and bladder, and they're going to have very long-term side effects. And we'll talk about that a little bit later. And we're only going to hint on that because you'll get more of that down the road with your chemotherapy courses. So now with this tandem and ovoid brachytherapy, as you can see here in the top picture with the metal, there are 3 things. The curved thing is actually inserted into the uterus, and the 2 white marshmallow things are inserted on the side to aim towards the ovaries. So if you have cervical cancer, you're probably going to get tandem and ovoid brachytherapy along with external beam therapy because there's less morbidity and mortality than with a hysterectomy. This is a 1-to-1 patient-nurse ratio. The patient comes in, they'll get their IV hydration. The worst part from what ladies tell me, if they can get the spinal and it takes well, is laying on the blue sliding board. They're put on that board and they may be on that board for 3 to 5 hours. Once all of this apparatus is inserted, they may not move. No, Alicia, they may not roll over. You may not sit them up, because if you would sit them up, that one thing in the uterus could perforate out the back of the uterus, causing issues. The biggest issue would be if you didn't know that during the CAT scan planning session and it's perforated out, you'll be treating outside of the uterus, causing long-term, maybe irreversible side effects. The planning's done every time, and for most people, it's 5 treatments, like I said. Now we have the Gamma Knife machine. The Gamma Knife machine, we actually trained here in Lancaster, Hershey, to use the Gamma Knife machine, just so you don't believe those commercials. The Gamma Knife machine is another live source, and so it is always radioactive unless the doors are shut. Only special people, certain people who need to be in that area, get Homeland Security to make sure that they are safe to be around that much radiation. As you can see, if you look at the top picture where the patient's head is, there's kind of like this head frame that you notice by their nose. Again, this is one-to-one nursing. It's an all-day procedure because when this is screwed, the head frame is screwed into their head, they get the planning session and then they have to wait for the calculations to be done. After the calculations are done, as you see that big metal thing above her face, it's kind of like part of a helmet. There's 201 plus holes there, and there's 4 or 5 different helmets with different size holes. And the radiation beam is then directed through those holes. What is so good about the Gamma Knife machine for people who are candidates for it, and more importantly, for people whose insurances pay for it, is it can pinpoint the tumor, treat the tumor from the inside out, and spare the rest of the brain tissue. By sparing the rest of the brain tissue, young people are less likely to have a secondary cancer from having radiation to the head. They also won't have as many neurological deficits down the road, and there won't be as much brain necrosis. Correct, Sam. You should not have to worry about health insurance as you're going through a cancer diagnosis. Sorry about that motorcycle, folks. Should have shut the windows. Gamma knife is done on brain tumors and trigeminal neuralgia, which is when cranial nerve 5 is a little hyperactive and it's causing face pain and it's not being controlled by medications. They can come for radiation, gamma knife, and they can go ahead and have that nerve deadened, shall we say, to shut the pain down. Radiation for gamma knife is again an all-day procedure. They come in, they are NP overnight, they get an IV, they get Ativan, IV, fentanyl, go for a quick MRI, and then they kind of hurry up and wait for the plans to be done. It is 1 nurse per patient because of the fact of the fentanyl. The head frame is screwed in, and some of the side effects from there, the biggest risks, of course, are infection. You're screwing something into the skull, headache, nausea, or seizures. This is the newest machine out on the market for the last couple of years. It's called a CyberKnife machine. Eventually, this may take place of the Gamma Knife machine. It is a man-made source, so therefore it's safer to control. And the arm, which you see at the top of the page, can go 360 degrees around. It can come in from multiple angles. It can almost lay on top of a patient. The black bed can also turn 360 degrees any way you want. So there's no head frame. So right there, we've cut down on the side effect of an infection. There's no real surgery. There's no hospitalization. There's no hardly any recovery time. There's no need to give them any type of pre-med. So therefore, you don't have to worry about them being home and having an allergic reaction or possibly being, well, unconscious and the family member not knowing. It's very precise treatment. So healthy tissue is really spared. And usually most people who get a CyberKnife, and we're treating that right now locally for lungs and brains, are 1 to 5 treatments. When a lung is being treated, the really fascinating thing about this machine is that they put a tight vest on the patient and the machine will learn their breathing pattern, inhales and exhales. And then the doctor decides, depending on the tumor, do we treat on the inhalation or the exhalation? Well, Sam, that's a good question. Some of these treatments can be 1 to 4 hours long, depending. And if a patient happens to fall asleep and start snoring and they weren't snoring during the planning session, that'll reset the whole machine with how the breathing pattern goes. These are the references from the slideshow that you just saw. And now we're going to talk a little bit about the side effects, simply because those are from my day-to-day knowledge, so I really do not have references for those. Radiation works by damaging the cell during its life cycle. So as the cell is getting ready to divide, radiation will be delivered. It will damage that cell. It will no longer be able to divide, so therefore it will become a dead cell. No one is radioactive after the beam is turned off, including gamma knife or the high-dose radiation, with the exception of the prostate brachytherapy, which we just reviewed. Side effects from radiation are local to the area treated and what lies underneath it. So if we are treating someone with a leg cancer and they have nausea, that's not from radiation. If we're treating someone to the head and they have a rash suddenly developing all over their body, that's not from radiation. So you need to think about where the treatment's delivered and what's underneath it. Almost anyone who's had 10 plus treatments, though, will have some sort of a skin reaction. And the skin reaction will kind of get red and be a little brisk. No, Danielle, we do not call it a sunburn. It's not like a sunburn. It is an expected radiation reaction. And it slowly gets from pink to a little bit redder. There could be blisters, but we don't grade them in first degree, second degree, anything like you would a burn victim, because this is an expected type of reaction. And it all depends the body habitus and also where it's being treated. If someone built a little overweight like me, if I had breast radiation, I might have open areas under my breast 20 days into the treatment, 25 days in. Someone who's very thin and we're treating a bony area that's sticking out, like at a collarbone, they might get more of a brisk reaction there than someone built like me where you're treating a collarbone. So, and this is one of the reasons why the nurses see the patients every week, the doctor sees the patient every week, and the radiation therapists see them daily and will alert if there's something that seems out of the normal or the patient's really having issues with. So now that concludes our time here tonight together. We don't meet again until the end of the month in class. In the meantime, you do have a Blackboard assignment, which has to do with a fact swap assignment, where you're going to go in and put down 6 facts that you learned tonight. And then you need to log on to 2 of your peers' areas and enhance their facts. Don't forget to use APA format and proper citation. And then you will all actually, if you look on Blackboard, you have been assigned to work in 3 groups of 3 with a specific type of cancer. And there's criteria on what you need to bring to facts and teach the rest of your peers. Prior to coming to class, though, please send me the questions required so that we can test each other's knowledge. Any questions before this lecture is over? Okay, have a good night.